Good evening. So today our meeting, the lecture will be given by the Dr. Tarec Christoffer, El-Galaly from Denmark. He will be our esteemed guest speaker for the evening. The topic is CNS relapse in DLBCL, 3 aspects: stratification, prophylaxis, and treatment. It is organized by Mumbai Hematology Group. It is supported by MCure Pharma. Logistical support is provided by the Perfect Square. So I'm thanking you, Mr. Kwood Soni and team MCure, Mr. Yash Kalpesh and the team Perfect Square, entire executive committee of Mumbai Hematology Group. Our guest speaker is Professor Tarec Christoffer, Denmark. All our discussions who are themselves eminent hematologists or medical oncologists from the country, and you participants for sparing your Saturday evening. Today our discussions are Dr. Aditya Murli, consultant medical and hemato-oncologist, bone marrow transplant physician, Aster CMI Hospital, Bengaluru. Akanksha Garg, associate professor, Department of Medical Oncology, Hematology, AIMS Jodhpur. Dr. Aniket Moite, consultant hematologist, bone marrow transplant physician, Jahangir Hospital, Pune. Dr. Darshana Rane, consultant medical oncologist, Nanavati Super Specialty Hospital, Mumbai. Dr. Dharma Chaudhary, director and head, bone marrow transplant, blood and bone marrow transplant, Sanar International Hospital, Gurugram, Haryana. Dr. Hamza Dalal, associate consultant hematologist, Department of Hematology of my own hospital, Fortis Hospital, Mulund, Mumbai. Dr. Hashmukh Balar, hematologist and BMT physician, Surat Hematology Center and Kiran Hospital, Surat. Dr. Kripa Bajaj, consultant medical oncologist, Basopa Tarakam, Indo-American Cancer Hospital Research Institute, Hyderabad. Dr. Krishnaratnam Kannan, consultant hematologist, Sri Ramachandra Medical Center, Sundaram Medical Foundation, Chennai. Dr. Mukul Agarwal, assistant professor, Department of Hematology, All India Institute of Medical Science, New Delhi, which is one of the most prestigious government medical college in our country. Dr. Muralidharan, Super Specialty Medical Hospital Officer, Borivali, Mumbai. Dr. Shilpa Prabhu, consultant hemato-oncology at BMT, Majumdar Shaw Medical Center, Narayan Hridayalaya, Bengaluru. Dr. Smita Kayal, associate professor, Jawaharlal Nehru Institute of Postgraduate Medical Education and Research, Puducherry. I am one of the alumni students of this prestigious institute. And now I am I'm just introducing the guest speaker, Professor Tarec. So he is professor at Aalborg University Hospital, Denmark. He's a consultant hematologist working primarily with lymphoma. His primary research focus is on clinical epidemiology and generating real-world evidence within the field of hematology as well as on PET imaging. He leads the epidemiology and real-world evidence research group for hematology at the hospital. He has published more than 90 papers in peer-reviewed journals, including several papers in high-impact journals. CNS relapse in DLBCL, stratification, prophylaxis, and treatment. Thank you. So now, Professor, just please just go ahead with your presentation. We will be eagerly waiting to listen to him, and then we just go for the question and answer session.
Thank you very much, Dr. Sanail, and thank you very much all of you for spending Saturday evening with me here. It's a great honor to be here again. I actually I did a presentation maybe half a year ago, and I really enjoyed it. So today's presentation, I'll just share my screen. I think you should see it now, right?
Yeah, absolutely clear. We just go to the slide presentation mode.
Yeah. Okay, so today's topic is really, probably I cannot bring as much clarity to what to do today because it's a really controversial topic. It's a topic of CNS, secondary CNS involvement in diffuse large B-cell lymphoma, and I'll be discussing a little with you who is at risk, who is at sufficiently high risk to do some preventive measure or diagnostics, and how can we prevent secondary CNS relapse. And how can we manage it? And first of all, it's important to agree on what we're speaking about. So when we talk about secondary CNS lymphoma in diffuse large B-cell lymphoma, it means that this is parenchymal or leptomeningeal CNS involvement that was not present at the time when they started first-line treatment. It may have been asymptomatic, but at least it was not detected, and the treatment selected for first-line did not really include any good CNS penetrating agents. So it can present both as a systemic relapse with CNS involvement, but it can also present as an isolated CNS involvement. And I think the main reason why this occurs, that's my thoughts, but I think it's very covering for all situations, is that it's untreated or suboptimal treatment of asymptomatic involvement already at diagnosis. And I think that actually is a substantial part of this, because we see very early relapses. So likely some of those that we actually call relapse had already had some CNS involvement at the time of diagnosis, but was just asymptomatic. And then, of course, we can have the more like secondary CNS lymphoma in its classical terms, that you actually have a spread to CNS after you complete your first-line treatment or during your first-line treatment, because the disease actually spreads really to CNS or recurs in CNS. It's really a huge challenge, and it's been a huge challenge for a long time. There was some initial thoughts that the introduction of rituximab, which is really the only or the last recent big advancement in diffuse large B-cell lymphoma. I know that polatuzumab may also be increasing PFS a little, but rituximab is still, I think, R-CHOP is the main treatment in most countries, including Denmark. But there was some thoughts that maybe the addition of rituximab brought some better remissions and thereby also less CNS relapse. But there's been done a meta-analysis of almost 5,000 patients, and there's really no clear effect of rituximab. So it seems like the overall prevalence of CNS relapse, the overall proportion of patients, unselected patients that will experience a CNS relapse is around 5%, and this has been unchanged. Some studies though have shown a small decrease in secondary CNS lymphoma, but generally, like you can cite the number of 5%. That's probably very covering for all time eras in the last 30 years. And also, it doesn't really seem like the addition of rituximab to CHOP really changed the kinetics of secondary CNS lymphoma. It's more or less the median time is around 7 months in both cases. This is a quite interesting paper, because I think this says something about CNS relapse, that it's really a different type of relapse than most relapses. And this is a paper out of an American study where they looked at all the relapses. And if you look at the kinetics of the relapses, and the time is on the x-axis and the y-axis is the accumulated relapses, and this is only looking at relapses. This is why it's 100%. Then you'll notice that the CNS relapses is really occurring much faster. So within a couple of years, virtually all has occurred. And another finding in this study was that it was 100% fatal. Now, I will come back to that later, because I don't think that this is completely true for today. I don't think the outlooks are that dismal, but it is definitely a serious complication. Yeah, so here you see the survival. If you don't have a CNS relapse, you have a survival that's very recognizable, maybe in the more pessimistic level here, but still around maybe 30% after 5 years are alive with a diffuse large B-cell lymphoma relapse, whereas the patients with CNS relapse are all dead within a couple of years. Do you see my cursor when I move it? Okay. Okay, I assume you do. So why is secondary CNS lymphoma a clinical challenge? It's a clinical challenge because it's such a rare event. It's 5%, and it makes it very difficult to study, and it makes it very difficult to develop really good evidence-based strategies. And another complicating thing is that there's almost no, or really no, very strong risk factors. It means that all risk factors are rather weak, and maybe increases risk somewhat, but not sufficiently high to really say that you're convinced that this patient is at very, very high risk. And of course, it's a challenge because it has a very dismal outcome, and the symptoms, not only speaking of the symptoms as well, they are really devastating. So it's not just patients feeling sick, they are also often becoming very mentally impaired and with very poor performance status, and it's actually the whole family often suffering in this situation. So solutions to this could be that we try to understand better the risk factors for secondary CNS lymphoma, because as it is now, as I showed, it's 5%, it's 1 in 20 in all comers, and this is really too low to substantially alter management for all patients. So imagine only 1 in 20 patients will benefit from some radical change in treatment to prevent CNS relapse at the expense of a very high risk of toxicity, because typically CNS penetrating agents or high intensity treatment is much more toxic than, for example, standard R-CHOP. The solution is also really to see if we can prevent secondary CNS lymphoma from occurring in the first place, a proactive approach rather than reactive. This is what we have tried for several years, but not so successfully. I'll show you that later. And then also develop better treatments for secondary CNS lymphoma. And I think we are really improving on that point. Maybe we are simply just not so pessimistic anymore, and we actually dare to try intensive treatments, and they actually sometimes work, especially for selected patients. So who's at risk? I think you can group the risk factors into 3 different areas. So I made it as circles here. You can have the organ specific. This is the most classical risk factors. This is when you have involvement of DLBCL in specific organs, then you may have a very high risk of CNS relapse, maybe for some biological features that makes exactly this lymphoma home also to CNS. We know there is some biology today that also increases risk of CNS relapse, although this is a little controversial still, I would say, but there's some new data on new genetic subtypes that may be very interesting. And then you have the clinical features such as age, performance status, LDH. And really what we need to do with all this, because as I said, every risk factor is rather weak, we need to have some models that collects risk factors and identifies patients that are at substantially increased risk. This is a very academic discipline, and I would say that you can make a lot of exercises to make risk groups for CNS relapse and find risk factors and so on and so on. But I think overall, you can say that with very few exceptions, then low risk diffuse large B-cell lymphoma is actually also low risk for CNS relapse. So typically what you end up in these models is, with few exceptions I'll show, is that a patient that is generally a very, very high risk DLBCL is also high risk for secondary CNS lymphoma. And if you have a low risk DLBCL, typically they would also be very low risk for secondary CNS lymphoma. So it's quite simple actually. So the organ-specific risk factors, as you know, kidney adrenal involvement is really a strong risk factor for CNS relapse, and testicular DLBCL as well. And then there is a number of additional sites that is a little more controversial and this well studied. It's breast lymphoma, it's facial sinus, it's female genital involvement, and it's, for example, location of lymphoma very, very near to the CNS, for example, epidural. So testicular DLBCL is a really interesting disease. It's a rare site of involvement. It's approximately 5% of males. And primary testicular DLBCL has a really unusual clinical course with very late systemic relapses, very late secondary CNS relapses, actually very unlike what I just showed before. It's sometimes several years later. And it also has a very special relapse pattern to the contralateral testis. And it also has a very distinct biology. It's typically ABC type. This is not very distinct, of course. This is near to half DLBCL patients, but they also often carry the MYD88 mutation and CD79B mutations, which are very similar to what you see in primary CNS lymphoma as well. So there's probably some biology here that makes this specific disease home to CNS. And this is also what you see in patients with secondary CNS lymphoma. Actually, they have also in the CNS biopsy also quite high frequency of MYD88 mutation. And of course, or unfortunately, we don't know much about CNS relapse because as you know, it's quite difficult to get a lot of tissue out of CNS, and this means that the biology is not really that well studied. So for testicular lymphoma, we have long known that this is a high-risk feature for CNS relapse, and that's also why we do have a special treatment for those patients. This is one of the only groups still, at least in Denmark, that make it IT treatment. So typically R-CHOP plus IT plus radiotherapy for contralateral testicle. But even in spite of this, and it's a limited stage disease, then the 5-year PFS is 74%. So it's actually still much lower than what it would be expected for non-testicular DLBCL of limited stage. As I said, this has a really special relapse pattern, and this is a large study out of British Columbia of 134 patients. It's a long time period, so it's even before the rituximab era, but they found more or less similarly that rituximab added to CHOP for testicular lymphoma didn't really help much in reducing the risk of CNS relapse. But if you see here, the black and gray curves, not the stipulated ones, then you see that despite the addition of rituximab, there's still a similar risk of CNS relapse. Whereas when you look at the risk of systemic relapse or non-CNS relapse, then it's clearly greater without rituximab. But if you look here, then even after 10 years, you see events, and this is actually, it's very special because typically you say when you're alive with DLBCL after 2 years, you're more or less cured, or maybe after 4 years, but this is really unusually rare events. And the median time in limited stage testicular lymphoma, like the stage 1 to 2, the median time to CNS relapse was actually 5.4 years. That's extremely long. Generally, the median was 2.3 years, but if you only look at the limited stage, not the stage 3 and 4, but the limited stage is much longer. And if you have concurrent involvement of kidney or adrenals, then it's a really high risk. It's a 75% risk, although with the caveat of very small numbers. So for kidney adrenal involvement of DLBCL, it's very similar. It's also a rare involvement, but unlike the testicular DLBCL, then isolated kidney adrenal, like limited stage disease with kidney adrenal involvement, is quite rare. Most of them are actually already stage 4 and probably having additional high-risk features. And the majority of secondary CNS relapses secondary CNS lymphomas in patients with kidney adrenal involvement occurs at first relapse and very early. So we're not talking about patients with multiple relapse. We're talking about at the first relapse, they will have CNS involvement. And also, as you know, the only organ-specific criteria in the CNS IPI is actually kidney adrenal involvement, not even testicular. If you look at this is from Dr. Villa from British Columbia, you'll see that they have a very, very high risk of CNS relapse, and it occurs very early. It's up to 40%. But again, small numbers, but it has been reproduced several times. So there's no doubt that kidney adrenal is really a high risk feature. We also had a look at this in the PET-CT era in around 1,500 patients, and if you see kidney adrenal here, it's 4% of the patients. In the multivariate analysis, they have a more than 3 times higher risk of secondary CNS involvement, and this is the same for testicular involvement. It's a 5 times higher risk. So clearly, still risk factors and confirmed multiple times. So what about female genital involvement by DLBCL? That's a little more controversial. So it's very rare, uterine or ovarian involvement, but a Chinese study initially found out of a little more than 300 patients that 2% had primary genital DLBCL. That means stage 1 or 2 with primary involvement of uterus or the ovaries. And in 4 of 6 of these patients, there was a CNS relapse. So it's really high. It's almost like patients with both testicular and kidney adrenal involvement. So we also did this in a study, looked at this in 678 females. And what you see here, we found some different numbers. We really saw that, first of all, the majority of patients with ovarian or uterine involvement were stage 3 or 4 already. So we only had 3 patients with uterine involvement that was not stage 3 or 4. So typically, in our experience, this comes with advanced stage disease. But if you look at the data we had here, then clearly this was also a very high risk for CNS relapse. You'll see here that patients with uterine involvement, but not testicular involvement, not ovarian involvement, but only uterus involvement had a very, very high risk of CNS relapse, whereas ovarian involvement actually wasn't that strong a risk factor. So the caveat of this study is that, as I said, we only saw this involvement typically in the setting of very high risk disease already. So our data didn't really support that limited stage uterus involvement was a risk factor, but definitely if you have it in the combination of other high risk features, then it's a really high risk of CNS secondary CNS involvement. I would say I still would like to see this reproduced in other series. So if any of you have large patient numbers or data, please look in your data and see if this is really a risk factor or not, or if it's just a spurious finding. So additional high risk features, breast involvement in women is also typically cited as a potential high risk feature. And if you look at the rates here, the crude rates, it's everything from 5%, which is more or less standard average, to up to 16%. But this is, again, I would say not really clear if this is only patients who have additional high risk features, or this is really localized breast involvement that is a big problem here. So on the conclusion of high risk sites, I would say that kidney, adrenal, and testicular involvement definitely high risk sites. And then we have additional sites that may be associated with increased risk, that's breast involvement, maybe female genital involvement, maybe additional sites like paranasal sinus or CNS near-location. This is really uncertain. There is data from the rituximab areas saying that like sinus involvement in the face, facial sinus, is not really a risk factor anymore. So to speak about the risk models, as you know, and as I said, just that actually most patients don't have any involvement of these high-risk sites. It's quite rare to have a testicular, kidney, or uterine or whatever involvement. So most of the patients who eventually relapse in the CNS never had involvement of any of these high-risk sites. And this means that we need to be better at capturing this type of relapse, and also means that it is, as you know, a likely multifactorial event. It's caused by both the tropism of the tumor and biological risk factors and clinical risk factors. And we need really to capture this in risk models. And there's been so many risk models over time. I'll only show one of them because this is what is used today. This is the CNS IPI. This was a collaborative study between the German high-grade non-Hodgkin lymphoma study group and then the BCCA, British Columbia Cancer Agency, in Vancouver, Canada. And the model was initially developed in the clinical trial data. So this was with government and with limiting inclusion to rituximab treated patients, of course. And the training cohort was more than 2,000 patients between 18 and 80 years. The validation was in the BCCA population, also from a long rate over a long period, 2001 to 2013. So the Cox regression analysis identified 4 IPI factors that were really significant, and then they evaluated the additional external sites that were thought to be associated with CNS relapse after adjusting for these, so that they really tried to see the contribution of an individual external site in the absence of all the other high-risk features. And this is what they came up with. These 5 risk factors, 6 risk factors, it's more or less identical to the IPI. And then we'll have the kidney adrenal involvement here as well. And they took the external involvement into this model, despite the hazard ratio being 1, for reasons I don't quite understand, unless maybe it's just because it's easier to remember that you just need to recall the IPI and then add kidney adrenal. The testicular involvement was actually not a risk factor, but of course in the population-based study from British Columbia, it was. And the reason for this, that was probably being that this was a model primarily developed on prospective trial data, and typically patients with localized testicular involvement may not be involved in or enrolled in these trials, and maybe treated outside the trials with a different treatment schedule. So the model divided patients into 3 groups: those with 0 to 1 risk factors, those with 2 to 3, and then those with 4 and above. And the 4 and above risk factors is typically it's called the high risk group, and this is expected 12% risk over 2 to 5 years for CNS relapse. We also did a validation of this in PET stage patients, also patients from the real world setting, not clinical trial data, and more or less see the same pattern that the high risk group has a risk of slightly above 10%. We also did something additional, and this is what I said before, that high risk DLBCL is typically also just high risk for secondary CNS lymphoma and vice versa. We looked at this only counting the number of external sites as a predictor of CNS relapse, because you can argue that the CNS is just an additional external site to be involved. And when you see here, if you just discriminate between more than 2 sites, and this is not more than 1 site as typically used in IPI, but more than 2 sites and less than 2 sites, you also have a very good discrimination. But this model has some limitations, and the problem for working with these models with still very low risk of CNS or quite low risk of CNS relapse in the high risk groups and very weak risk factors is that even if you try to achieve a maximal sensitivity and really want to capture all patients with CNS relapse, then you will end up having a very low positive predictive value because of the risk factors are so weak. And in its current form, the three groups that we create with the CNS IPI, then we also have to recognize that most of the CNS relapses, or at least around half, actually occurs outside the CNS IPI high risk group, because the majority of patients will be in the non-high risk group, and they still have a 2 to 3% risk, at least in the intermediate group. So like numerically, you will have just as many CNS relapses outside the high risk. And also the consequences, if we were to use this very actively in the clinic, is that if you, for example, use the CNS IPI to select patients for let's say, like giving CNS prophylaxis or CNS station, then you need to do quite a lot to avoid one case. Like you need to treat 10 patients with high risk disease to avoid this one case of CNS relapse that would have occurred. That means that 90% of the patients are treated unnecessarily with toxic agents. So the solution is really to make better risk models, probably just by advancing the statistics. Maybe we don't need these 1 + 1 + 1 risk scores anymore. Maybe we can do a little more sophisticated. And then we, of course, need some kind of app to calculate what the actual risk is, but we can probably do much better individualized risk predictions. And then we also need to integrate more biology into this. And just briefly about the biological high-risk features, because this is very discussed recent years. So the double-hit lymphomas, as you know, this is a lymphoma that is typically very, very aggressive. The high-grade lymphomas with translocation of MYC and BCL2 or BCL6. But these patients are also often very much high risk for other reasons, because these are the patients you see with multiple times elevated LDH, with stage 4 disease, with multiple external nodal involvements and things like this, all what could be considered as high risk anyway. We also know that limited stage double hit lymphoma actually is not consistently associated with worse outcomes. So the question is if it's really the double hit that's driving a higher risk, or if it's just the fact that they have so much, such an aggressive presentation anyway. So double-hit lymphoma was in a study from MD Anderson associated with very high risk of CNS relapse, like 30%, but it's actually not much higher than what you would see in the CNS IPI high-risk group that didn't take account of any biological risk factors. But I want to say also that when you look at larger cohorts and maybe less selected cohorts, those out of the Mayo Clinic, which have really good population-based data, they tested 66% for double-hit lymphoma in a consecutive enrolled cohort. And patients with secondary CNS relapse and patients that didn't develop secondary CNS relapse actually had similar rate of double-hit lymphoma. So 2.4 against 4, 2.7 against 4%. So these suggests that patients that eventually develop double-hit lymphoma are not enriched for double-hit. And when you look at a multivariate analysis, then it's really, there's a trend for a higher risk, but it's not significant. So my take on this is that there may be some biological risk factors, such as double-hit lesions, but probably you have to look at how they clinically present, because if they don't present as a very aggressive lymphoma, then likely there's not it wouldn't be justified also to try to treat them, for example, CNS prophylaxis. For example, if you have a double hit that presents with stage 2 disease and only slightly elevated LDH or something like this, probably this is not high risk for CNS relapse. So in the family of double hit, we have the dual expressor lymphomas, which is typically in the ABC subtype of DLBCL. And there was an initial study out of BCCA suggesting that dual expressors really had a high risk of CNS relapse at 20% over 2 years. Also in multivariate analysis, adjusting for the CNS IPI, then you'd see that the dual expressor is really associated with a threefold increased risk of CNS relapse. However, this was not reproduced in 688 patients from the Goya trial. This was a clinical trial of obinutuzumab against rituximab in DLBCL. And I think maybe this is a suggestion that it's not really a risk factor, but it can also be a suggestion suggesting that actually there are so fundamental differences between real-world patients and trial patients that maybe looking for risk factors for CNS relapse in a trial population is quite tricky, because typically trial patients are more or less, I would say, like they are more or less cleaned for, or at least have a much lower rate of really high risk disease, because you need to do all the screening, you need to do PET-CT, you need to do maybe sometimes wait for biopsy for central review and enrollment, and so many things that if you're really a high risk DLBCL and high risk secondary CNS lymphoma, like the ones with multiple times elevated LDH, then they can't wait for treatment. So this may be why we see some differences when we look at trials versus real-world cohorts for looking for CNS relapse and risk factors for this. So cell of origin has also been proposed as a risk factor like the ABC, and also based on the Goya study, a new model was developed that included the cell of origin and CNS IPI. And looking at the cell of origin here, if it's an ABC and they have CNS IPI high risk disease, this means that they need both. Then they have a 15% instead of the 10% risk for CNS relapse. But again, if you look here, and this is the big problem, the high risk group here only accounts for 75 patients out of 900 and something, almost 1,000 patients. And this means that even though you have a small group with a very high risk, then the bulk of patients that will suffer from a CNS relapse actually is in the blue and the green curve. So it isn't that helpful. So just some more recent data, I think it's very intriguing, but it's also very immature, and it's based on few patients. So again, if you have genetic data on DLBCL and don't know what to do with it, then this probably would be a very good study to reproduce. This is the new lymphoma classification by Stout's group, where, as you know, they had a mixed connective tissue type the MCD. This was interesting because this MCD type was enriched for MYD88 and CD79B mutations, and this is typically what you also see in CNS, in primary CNS lymphoma. And when you look at the CNS relapses here, you'll see that patients with the MCD subtype in comparison to GCB or P53, they have really a much higher risk of CNS relapse. A much higher percentage of patients with relapse had involvement of CNS when you had the MCD subtype. Sorry. So maybe this is something to look out for. Let's see if it's reproduced. So how do we prevent secondary CNS lymphoma? And I honestly have no answer to this question. I will review some of the literature and then eventually end up concluding that this is still very uncertain, unfortunately, how we best do this. And if what we do today is working at all, or if it's working sufficiently to justify the added toxicity. So prophylaxis against secondary CNS lymphoma, this would be to prevent a later secondary CNS lymphoma. And this is actually, it's an interesting concept, because what you actually want to do is prevent relapse occurring to the CNS months to years later after commencing your first-line treatment. But of course, if you use, for example, methotrexate, this is not staying in the brain for years. So somehow the word prophylaxis in this setting always puzzled me, because I think what you're really trying to do when you use CNS prophylaxis is to treat patients with like microscopic or minimal involvement of CNS already at the diagnosis, so that you avoid that this eventually present as a relapse. Because how would exposure to high dose methotrexate several years before prevent that you later relapse in the CNS if it wasn't because you actually cleared microscopic involvement upfront? But that's just my puzzling with the words. One thing I want to highlight is that also adding to the talk about risk of minimal involvement already diagnosis, is really that the simple prophylaxis, and what we really should be good at, is to screen patients appropriately at baseline. So, and who should be screened? That's a good question. But patients with symptoms, of course, but patients also maybe inquire patients very thoroughly for symptoms, and also consider that those patients with very high risk kidney, testicular, double hit with high risk features, all these things, maybe they should receive a lumbar puncture with flow. Maybe they should also receive an MRI of the brain, and then you will capture and classify the patient correctly up front. That's probably a very efficient prophylaxis. So I think the first really systematic use of CNS prophylaxis has probably been for the testicular lymphomas, and this is also one of the diseases, despite its rareness, that has been quite well studied, although only in phase 2 studies. So this is from the El-Galaly study, where they included patients with limited stage follicular lymphoma, and they treated them with R-CHOP, but also with 4 times intrathecal methotrexate, and then also radiation. And if you look at the CNS relapse rate, here that's the yellow, the solid yellow line, then it's quite low. So it's around 5% after 5 years, and this is quite low compared to at least the historical data. But if you also look at the confidence interval here, and it's very few patients, then you'll also acknowledge that it goes all the way up to at least well above 10%. So the actual reduction, I think, is still uncertain with this approach, but at least that's a relatively easy treatment. It's relatively simple, and the IT treatment has no, it certainly does have risk, but it's not as complicated as giving high dose methotrexate, for example. But not to say that it's atoxic. There can be serious complications to IT treatment as well. There was a systematic review of IT treatment recently, a strong factor for reducing the occurrences of secondary CNS lymphoma. But as I also commented, then the studies are not really designed to address it, and there's a low event rate and there's a bias. So every one of these studies had a very low risk of CNS relapse. And this is, of course, making it complicated to really study the effect of a prophylactic treatment. And then also the bias, because if you're not randomizing for IT treatment or any CNS prophylaxis, then you would probably be biased to give patients with very high risk more likely to receive IT treatment or other CNS prophylaxis. And then you may not even capture this small reduction, because within the high risk groups, there's, of course, even if you try to adjust, you can have elevated LDH a little bit, or you can have 5 times elevated LDH. But typically when you do these adjustments, you just say like above normal or something like this, and then you have a lot of residual confounding. High-dose methotrexate has become quite popular, and I think it has a good rationale because IT treatments probably has a very limited penetration to the parenchymal areas of CNS, like into the brain. And we know that most, or at least many, CNS relapses occur in parenchymal form and not leptomeningeal. So we really need, if we really believe in CNS prophylaxis, we need something that penetrates the brain much better than IT treatment alone. And it's also, as you know, we know that it's very effective in penetrating because we know it's very effective in treating CNS lymphoma. And what we have done typically is to adopt treatment schedule from primary CNS lymphoma into use for CNS prophylaxis. So typically it's 3 grams per square meter over 3 to 6 hours. But actually there's so many unknowns in this. We don't know the number of infusions to use. We don't know the optimal timing. And we, of course, don't know the efficacy from randomized trials. We have some single arm trials and we have observational data that I will review, but they are very contradicting. I think the big question, as most of us face, is whether we should try to give high-dose methotrexate intercalated, or we should do it post-R-CHOP. And intercalated, that means that you give it between the first cycles of R-CHOP in the beginning of treatment. And this has the rationale that if you have microscopic CNS involvement, something like this, then it's probably more effective to treat it very sufficiently upfront. And there is some phase 2 data that shows that patients that have received this treatment have a very low risk of CNS relapse. However, it's also quite complicated, as you know, and it's not atoxic to give high-dose methotrexate, and sometimes you need to postpone R-CHOP, or you end up having kidney problems or severe mucositis, and it's not really a nice treatment for patients. It requires a lot of in-hospital time, and as I said, quite complicated and resource heavy because of all the dehydration. So what you typically also can do is giving it post R-CHOP. That's a little more simple, so you don't need to push it in between the R-CHOP, and then you know that patients get the R-CHOP on time. And we also know that this is actually important to have sufficient systemic control of disease. So there's a review in press, it should be out soon, where we looked at the literature about CNS relapse, and we looked at both. This is just reviewing the observational studies, and as you see here, there's a list of studies suggesting that it works, and there's a list of recent studies suggesting that it doesn't work. So it's all over. But what you can say generally about these types of studies, and what we run into of problems, is that it's typically a low number of patients. So if you only look at 200 patients and you know maybe a maximum of 10% experience CNS relapse, you have 20 events, then if you are to detect an efficacy of CNS prophylaxis, then it has to be incredibly effective. So it's also not fair to expect detection in very low numbers of patients, but nevertheless, that's what has happened sometimes. But there's a lot of bias in these studies. Again, as I said, you can imagine that you give patients with very high risk, even though you both have 2 patients that have CNS high risk disease according to the CNS IPI, that can be high risk and then can be very, very high risk. And maybe you will tend to give the very, very high risk the prophylaxis. On the other hand, you can also imagine that the very, very high risk are so sick from disease, they have so high LDH, they have multiple problems, poor performance, that they're actually not able to tolerate high-dose methotrexate and therefore are not getting it. So there's so many explanations that go in all directions. We have a Nordic study published a year ago, the CHIC study, where we used this approach where we gave high-dose methotrexate up front, very early in treatment, and then also gave consolidation with RC in the end of treatment. And this was mixed with R-CHOP and subsequently with R-CHOP, so addition of etoposide. So it's a quite heavy treatment, and also only for patients less than 60. So the median age was quite low, 54 years. And if you look at the CNS relapse risk by this approach, it was quite low, as comparing to that it was actually high-risk patients included. It's only around 2%. But again, here, it's a really low number. So the confidence interval, which is not shown here, is really wide. But when you look at the previous study from the Nordics, where CNS prophylaxis was given in the end of treatment, like high-dose methotrexate after R-CHOP, then you will see that the risk of CNS relapse in that study appeared to be visually higher. So it seems to be there seemed to be an effect of giving intercalated methotrexate, but it's not significant. So again, limited by small numbers. And again, one caveat here is also that this study, the recent study I mentioned, the blue curve here, they required pre-treatment CNS evaluation of patients. So that means that if you really do systematic screening of all patients before enrolling them in a trial, then you're also likely to exclude the patients that maybe have a very minor CNS involvement already at diagnosis, and this is maybe the type of patients that eventually develop relapse. So maybe you end up having like lower the risk of CNS relapse just by appropriate screening and not necessarily by the treatment you give. So we looked at this efficacy of intercalated high-dose methotrexate in a very large population of almost 1,400 patients to see what was actually most effective in preventing CNS relapse. And this was all based on observational data, so again, with the typical limitations. But if you look at the risk of CNS recurrence, then you'll see here that even if you look at the time of diagnosis, like count already at the time of diagnosis, this analysis will of course be biased towards a better effect of the end of treatment high-dose methotrexate, because if you get end of treatment high-dose methotrexate as CNS prophylaxis, that means that you have completed your full treatment of R-CHOP without having a CNS relapse. So this is a kind of guarantee time bias or immortal bias, and typically can be a flaw of observational studies. But even when you look at the time from diagnosis, then there doesn't seem to be a difference between intercalated or end of treatment. But you will notice here that there seems to be maybe a little higher risk of with intercalated. But again, this can just be due to the fact that you cannot have a CNS relapse early if you get end of treatment high-dose methotrexate, just by definitions of study populations. But when you look at the landmark here, looking only at patients completing their R-CHOP, then again, there's really no difference. And if you also look at like the total rate here, it's a little less than 10%, a little less than what you see in CNS high-risk IPI, but this is not all high-risk patients. So this was also this was all patients just as long as they had high-dose were treated with high-dose methotrexate. But in this study, when you looked at the high-risk patients only, then actually their risk was also around 10%. It's very similar to what was reported in the initial CNS IPI model, where patients had no CNS prophylaxis. So at least we cannot exclude that high-dose methotrexate based on this study works, but at least it's not a miraculous treatment. So you will still see CNS relapses even if you give this consistently to high-risk patients. You'll also see here just showing that if you look at the survival of patients, whether you give end of treatment or intercalated, you'll see that if you give end of treatment, then apparently you have a better survival. But this is of course a bias, because then you have to be alive for the first 4 months. and cannot die. Otherwise, you cannot have end of treatment high-dose methotrexate. But when you do the landmark analysis saying that we only look at patients that survive the first 6 cycles of R-CHOP, then there's no difference. So it has no impact on overall survival how you give your high-dose methotrexate. But what it does have an impact on is that if you give it intercalated, as you see here, then this is really a high-risk feature for having to delay your R-CHOP. And delaying your R-CHOP is associated also in this study and previous studies with a higher risk of systemic relapse or insufficient disease control. So my take on all this is that if you are to give high-dose methotrexate, I wouldn't go through the hassle of giving it intercalated because it's much more complicated for the patients. It's much more risky for delivering your R-CHOP. And for example, you don't want to see the kidney injury in already after cycle 1 of R-CHOP, and then having a complicated treatment for the rest of your necessary lymphoma treatment with R-CHOP, for example. So, or needed lymphoma treatment. So that's my take on it. We have done some more to look at whether, now I'm saying that it doesn't matter whether you give it or it likely doesn't matter whether you give it at end of treatment or if you give it upfront, intercalated. But the real question is, of course, does it work at all? So are we reducing the risk of CNS relapse at all by giving high-dose methotrexate? And this was looked at in a study we did together with our Australian colleagues and a lot of international centers looking at patients with high-risk disease for CNS relapse. That was high-risk CNS IPI high risk, like score 4 to 6, or involvement of these high-risk sites. And when you look at just the crude numbers, you will see that if you don't get like the vast majority didn't get any high-dose methotrexate because it was a long period of recruitment. So it was also prior to we actually developed this treatment strategy. But looking at the age, of course, if you give high-dose methotrexate, you are likely to be a little younger, and you're also likely to be in a better performance. If you look at the performance score here, 2 to 4, it's quite it's significantly fewer who had a poor performance score in patients that received high dose compared to patients that didn't receive high dose. So there are some imbalances, but if you look at just the crude rate of CNS relapse among patients who had high dose methotrexate and those who did not, and this is only abstract form yet, so we are still doing the final analysis. So this is not final numbers, but I think the final analysis will tell more or less the same. But you see that there's a risk of 9 to 7.9%. So it's not really substantially different. This is just crude numbers. When you look at the risk curves, adjusted risk curves, this is adjusted for differences between the groups, and also with competing risk. Then you see that if you get high-dose methotrexate, again, it's probably a little lower risk at some point, but eventually you catch up and it ends up at being the same. And again, here there is a bias in this because to get high-dose methotrexate either at end of treatment or intercalated, you're not allowed to develop a CNS relapse very early. So if you develop a CNS relapse after cycle 3 of R-CHOP and had planned high-dose methotrexate at the end, then you would automatically belong to the non-high-dose methotrexate group because this is an observational study and we had no information on intent to treat. We only know data like the as treated group, and this of course creates a risk of bias. But even despite of this, then you see that there's no huge difference. So it's around a 1% risk difference after 5 years, and be aware that this curve only go out to 20%. So even though it looks substantial difference here, you can divide it by 5 if you want to look at 100%, as we typically look at. So a risk difference of 1% equals that you need to treat almost 100 patients to avoid one case of secondary CNS lymphoma, and that is if it works. So when we look at this Vencia patients only to avoid the most obvious immortal time bias, then we see more or less the same results. So there's a small difference after 5 years, but it's really not huge. It's a 1.5% risk difference. Again, you need to treat a lot of patients. And who knows, like if you need to treat 60 patients with high-dose methotrexate, to avoid one CNS relapse, could you potentially have one toxic death from high-dose methotrexate, then you lose it also. So it's not a simple calculation, and it's not just straightforward what to do, but it's definitely, since it's not highly effective, then you definitely need to consider also the risk of unnecessary toxicity or potential serious toxicity that could be detrimental for the patients, not in the form of a CNS relapse, but because of a toxic death or because of serious kidney injury or something like this. So the conclusions of the CNS prophylaxis is really difficult because there are not really any conclusions. The role of IT prophylaxis is really questionable. I think that's the strongest conclusion I can make. We use it sometimes for testicular lymphoma, or we use it sometimes if you really feel that patients should have CNS prophylaxis but cannot tolerate systemic prophylaxis. But it's much less than we have done, and personally, I don't find it of much use, just also from the pharmacokinetic perspective, that injecting small dose of methotrexate in the cerebrospinal fluid, that doesn't really, in my view, would help to prevent a later parenchymal relapse. But maybe if you have a minor involvement of the leptomeningeal space at the time of diagnosis, maybe it has a role there or something like this in frail patients where you cannot give any intensive treatments. But generally, as a prophylaxis, it's not highly effective for sure. And whether high-dose methotrexate is a better treatment, that's also very uncertain. I think it's a much more popular treatment, and it has a much better pharmacokinetic profile. But there are really also caveats here. First of all, we have absolutely no randomized trials showing that it's effective, and the observational data are very inconsistent. And it's, as I said, it's really associated with toxicity as well. So it's not a free ride. It's burdensome. It's also, like, from a cost effectiveness perspective, at least in Denmark, we have these patients admitted to hospital for maybe 5 days while they get hydration, and after this they get the rescue treatment. So this is really a resource heavy treatment, and we are in a situation, at least in Denmark and most of the Western world right now, where we simply have no nurses left. So we really need to be mindful on how we use the resources. Our current guideline in Denmark says that you can use high-dose methotrexate, and for patients with kidney and testicular involvement, please, it says, like, please consider it strongly. But for all other patients, please consider very much pros and cons, and consider also the toxicity and the uncertain evidence. So it's really softened a lot, the use of high-dose methotrexate, because of these recent studies. And again, as I said, maybe the safest and best prophylaxis is just appropriate screening of high-risk patients for asymptomatic involvement. So the last thing I'll go through is the outcome of secondary CNS lymphoma, because I think that's a very interesting topic. It has been historically perceived as a very dismal situation, and probably also is, and it's maybe been perceived historically also as such a poor prognosis that you almost were tempted to just go straight to palliative treatment, saying there's nothing to do about this. And I don't think this is completely appropriate or true. And I just show this this recent publication from New England Journal of Medicine on the CAR-T treatment. And you see the standard of care in patients. This is progression-free survival. You see the standard of care here for patients with non-CNS relapse, like systemic relapse without CNS involvement. And the PFS here is despite use of high-dose therapy or intensive, at least starting with intensive salvage therapy, the PFS is really low. It's only around 30%. It's more or less identical to the Corral study, and nothing has improved, and it's a poor outcome. So the question is then patients with CNS involvement at the time of diagnosis, do they really have much poorer outcome here? And what I'm especially interested in what about the patients that have isolated CNS involvement? Because of course, if you have both systemic and CNS involvement, maybe we're in a different league of, like, in terms of seriousness, but maybe the isolated CNS involvement is not much worse than just having an isolated systemic relapse. Again, I'm showing this is older data. It's 15 years old or 13 years old at least, showing that patients with CNS relapse really have dismal outcomes, 100% mortality. Very discouraging, I would say. But nevertheless, I would say you should consider intensive curative therapy, especially for patients presenting, also for patients presenting with secondary CNS involvement. They should really be evaluated for if they can tolerate intensive multi-agent therapy with CNS penetrating regimens. And I'll show you some data on this to support this. And the patients that especially have good outcomes among patients with secondary CNS lymphoma are patients that have isolated secondary CNS lymphoma, isolated parenchymal involvement, and with a good performance and a young age. What I also will say is that there's no single regimen that is documented better than others, but likely very intensive regimens looking very similar to what you use in primary CNS lymphoma today. Probably also the need for an autologous stem cell transplantation as consultation, or what you also typically do for non-CNS relapse today, is probably the most appropriate. And then I also want to say that even if you have been exposed to high-dose methotrexate as a CNS prophylaxis, then this shouldn't preclude in treatment with high-dose methotrexate at the time of CNS relapse. There's no data that shows that having prior exposure to high-dose methotrexate as a CNS prophylaxis leads to worse outcome if you then develop a CNS relapse. So outcomes are really diverse. We did a review of a very large number of patients, all treated with R-CHOP initially. So this is the outcomes of secondary CNS involvement after R-CHOP. And the main findings we saw was that patients with isolated CNS involvement, they more often had parenchymal involvement as compared to patients with systemic and CNS involvement. And we also saw that if you have isolated CNS involvement, then you often have a much better performance. And we also saw that isolated CNS involvement often occurred with the first relapse. And the final thing also that isolated CNS involvement actually also rarely occurred during R-CHOP. And we know that patients that progress during R-CHOP is really facing a very dismal outcome. So it seems that there is a group of patients that have some favorable features. Patient with isolated secondary CNS involvement, young patient with a good performance. So we also looked at what are the high risk features 2-year overall survival in secondary CNS lymphoma, and what we found here was that typical high risk features, what was associated with worse outcome was higher age, probably and this is limited to patients with intensive treatment. So it's not just because they get palliative treatment, but probably if you start intensive treatment on patients with high age, probably it's difficult to complete. But high age is a poor risk factor. Performance status more than 1, which is a lot of patients with this type of disease. If you have leptomeningeal and parenchymal involvement, not just one of them, and if you have concomitant systemic involvement, and if you have secondary CNS progression during first line. So again, there's really also, from the high risk features, you can really also look at it the other way around and say there must be a group that actually do well, or at least better than expected, and these are the young patients, good performance, no systemic involvement, and isolated parenchymal disease coming after R-CHOP. If you look at the previous studies, I showed the one with intercalated high-dose methotrexate and post-treatment high-dose methotrexate. Then they also looked at whether prior high-dose methotrexate was associated with a worse outcome of secondary CNS lymphoma, and they didn't find that. That's also what I said before. The only consistent adverse risk factor, prognostic factor they found in this study was the age of the patients, but this was a low number of CNS relapses they had. This is again from the study we did, where I showed the risk factors before and defined the high risk and low risk groups. And if you remember the prior data I showed from the I guess it was the SUMA 7 study, the CAR-T axicell study, then you will see here that if you look at the curves of young patients with CNS relapse below age 60 treated with intensive treatment, it's not that much different from relapse in general. This is overall survival, so it's different from the progression-free survival. But generally, you see just by being less than 60, you have an expected outcome of around 30% after 30% survival after 24 months. So that's not that bad. At least it's not that bad that it justifies just giving palliative treatment for all these patients. And again, we also were able to identify this group, as I said before, the young patients with good performance. They actually had a 2-year OS of 62%, and that's much better than the average relapse, regardless of involvement of CNS relapse or not, regardless of involvement of CNS or not. This is much better than the average DLBCL relapse. So generally, this just because you have CNS involvement doesn't necessarily mean that you are completely unlikely to achieve a remission and completely unlikely to achieve a durable remission. You can actually be treated successfully, and you can actually achieve long-term survival. I just want to highlight one single study of this. I think this is the best one done. This is the Marietta study. This is a phase 2 study of patients up to 70 years. Actually, unlike other studies, it included patients with quite poor ECOG performance. Typically, otherwise, studies tend to take only the best patients. This is a patient that mixed what you typically treat primary CNS lymphoma with. It did a mix with this and what you typically treat systemic lymphoma with. It treated with 3 times matrix, 3 times ICE. And then in the responding patients, you gave a high dose therapy with Tarec conditioning, similar to what you can do in CNS lymphoma. And if you look at the data here, you had 43 enrolled patients with CNS relapse. The rest of the patients were patients. The rest of the 79 patients were patients that had CNS involvement already at diagnosis. So this is not the type of patient we typically call CNS relapse, but the bulk of patients had CNS relapse. But only 37% of the patients completed. So of 79 patients, 37 completed the high dose. This really also shows, as shown here, that there's a lot of loss of patients during the treatment. There's a lot of progressions. There's a lot of toxicity. It's a very intensive treatment. But if you look at the progression-free survival, this is really what I want to highlight here. Definitely, it's worse to have a relapse that involves the CNS than to have a CNS involvement already at the time of diagnosis. So the blue is patients that are involved with concomitant CNS and systemic disease already at diagnosis, and the red is the one we typically call CNS relapse. These are patients that had received one treatment for systemic lymphoma at one point and then relapsed with involvement of CNS. And this is PFS. And when you look at this PFS, it's actually not, with this intensive treatment, it's actually not that different from what you saw from a clinical trial recently with the standard treatment. Maybe it's 10% lower, but it's not that bad compared to what you can expect in systemic DLBCL relapse without CNS involvement. So again, it's a generally having a DLBCL relapse is a dismal situation, but having a CNS involvement as well doesn't necessarily make it completely hopeless. This is my last slide. It's just to say that also something new is happening for these patients. So we know also that interestingly that the CAR-T treatments actually works very well also in patients with secondary CNS lymphoma that penetrated the brain barrier, and it can also bring patients that have involvement of the CNS at the time of relapse into remission, even though these were not part of the phase 3 studies. Then has been some experience outside studies showing that remission rates are actually quite impressive. Okay, so I don't have much more to say on this topic. Thanks for listening and staying on. maybe I can stop sharing.
Thank you, Professor Tarek, for this excellent presentation. So I just request the panelists to just use the raise hand sign and pick the questions one by one. Dr. Krishnaratnam, please go ahead with the question.
Thank you. I have two questions. The first question is, we were sort of conventionally told that for lymphomas involving the breast or kidney, it's sort of mandatory to give high-dose methotrexate. But in one of your slides, I saw that's not wrong not to do. So I'm a bit confused. So what is the current practice when somebody has a breast lymphoma, involvement of the breast or a kidney or suprarenal? Is it optional or we should give high-dose methotrexate?
Yeah, that's a very good question. I unfortunately don't have like any definitive good answer on this. So as I said, in Denmark, we relaxed our criteria for CNS prophylaxis a lot because of recent studies showing that it's not that effective. We have a recommendation in Denmark saying that for kidney, adrenal, and testicular, you should strongly consider giving CNS prophylaxis. For all other situations that includes breast or just being seen as high-risk disease, it's optional. So you have to consider the pros and cons. You have to consider the risks of giving it, and you also have to consider the fact that it's even in the situation that it would be effective, then at least the data we have shows that it's not highly effective. So you need to treat a lot of patients to avoid one case. And then you can say, like, you also sometimes see serious complications to this treatment. So the total benefit risk for patients is really tricky. So when you meet an individual patient, this is, if you're very fit and you are completely sure that there's no risk of severe toxicity or something like this, then the likelihood that you can, or the balance may be tipping toward that you should try to give CNS prophylaxis, but just having in mind that there's really no data that really have documented this is highly effective. So that was a little like an answer, like a politician answer with no yes and no. I know, but this is because in Denmark we changed our view on this a lot. We changed it to being more like an optional for the individual physician to have a discussion with patient on pros and cons, because we don't feel that we can say clear now that we just recommend for all, because you need to treat so many patients, and you also face a risk of toxicity in light of lack of evidence for efficacy. So,
okay,
but for kidney, adrenal, and testicular, this is our favorite sites in Denmark. This is what we consider mostly strongest. Breast is not so much considered high risk in Denmark, I would say.
Okay, thank you. Just one more question. You have mentioned about MYD88 mutation. Those cases, will ibrutinib be any use?
That's a very, very good question. We know that ibrutinib can be effective in treating CNS lymphoma, at least bring into remission or response, and we also know that possibly ibrutinib in young patients, ABC type, is associated with better remissions, better survival. And what's really interesting, I think, is that the MCD subtypes, just recent data, the MCD subtype of DLBCL, the one I showed, which appeared to have a very high biological risk of CNS relapse, and the ones that had very high risk of MYD, or very high frequency of MYD88 and CD79B mutations, this group seems to respond extremely well to addition of ibrutinib based on sub-analysis of the Phoenix trial. So I think this is definitely something that's worth looking more into. I'm not sure if it can be recommended as a general strategy for prophylaxis as it is now, but I think this is definitely one of the more interesting aspects for the future, whether this more sophisticated genetic subtyping of DLBCL into the MCD or EZH subclasses, if this eventually leads to a difference in treatment strategies, and also maybe incorporation of CNS prophylaxis in very high risk patients. So yeah, so it's a good question. I don't have data to say that it works. I know, for example, if you look at lenalidomide, which is also penetrating the CNS, there were also big phase 3 studies that the robust trial, and also a study of lenalidomide in elderly, I think in a French study, they looked at the CNS relapse rates. And as I recall, despite giving lenalidomide to patients that could be seen as a prophylaxis as well, there wasn't really a substantial lower risk of CNS relapse in these studies. But again, as I also said before, looking at clinical trials and looking outside clinical trials can be very tricky with CNS relapse, because the very high risk of CNS relapse is typically in very ill patients, and these are typically outside the trial. So it may be very difficult to capture enough cases in these trials where you have these typical pharmaceutical industry trials where you have to go through so much screening that you eventually exclude patients with very high risk.
Thank you very much.
Dr. Kripa.
Thank you, Dr. Tarec, for the excellent talk on ambiguous topic. I have 2 questions I'll quickly ask. So it's a usual practice for us to add both HTM ticks and ITM ticks for patients who are at high risk for CNS relapse, especially the testicular tumor as well as kidney and retinal involvement. Do you think it's going to add any benefit to HTM ticks? First of all, HTM ticks itself, as I showed rightly the data, there's a doubtful benefit by adding HTM ticks. So do you think it's appropriate to give HTM ticks and ITM ticks both in a patient who is having a high risk for CNS relapse?
For testicular involvement, this is something I would consider as well. I don't think we have any data really saying that this is much better to give both. I think there is some, at least if you look at the pharmacokinetic data, I think when you give very high doses of methotrexate, at least in my, as I recall, then the exposure in the CSF is more or less as high as if you give IT. So I'm not sure if if you actually increase the exposure much by adding IT if you already give high dose methotrexate. But again, this is really unknown, and I think there's no right or wrong here. You need to do what you feel is appropriate and best, and then hopefully we'll have some data at one point showing what's the best practice. I do have one comment though, that I have seen a couple of patients getting like a myelopathy after IT treatment. So even though we perceive it as being a very atoxic, very simple treatment, then I have seen some concerning side effects sometimes. So in the case you give high dose methotrexate already, I guess I would need a strong rationale for giving additional IT in light of that you actually have a risk with it. But I'm not saying that there's a preferred way. This is exactly the controversy in this topic, that nobody can say this is wrong or this is right or this is how we should do. But if you give both treatments now, it would be interesting if you collect your data and report them and see how it actually works. It would be very valuable to have this added to the literature.
Thank you. And one more question, sir. So you mentioned in your slide that you consider for poor patients ITM-TX alone definitely than HTM-TX. So what set of patients who are having a better PS would you choose to give ITM-TX alone than HTM-TX? Is there any subset to select to give only ITM-TX? Yeah, so you're asking if there's patients that should only receive ITM-TX today. So I would say that the evidence for single agent ITM-TX to work is quite poor. So it's even poorer than for high dose. But in Denmark, we have it as an optional thing, saying that if you really feel that you need to give a CNS prophylaxis, but do not dare to give high dose methotrexate because of comorbidity, age, or performance, things like this, then you have the IT treatment as an option. But again, as when we write like this and say like this, it also means that you can say that there's, at least from our national perspective, there's no right or wrong. So you cannot like say to a physician that you should have given IT here because there was a high risk, because you don't really have the evidence that it works. So you can do it, you can also not do it. This is unfortunately one of the areas in hematology where we have to act very much without any good evidence guidance. Thank you so much, sir. Thank you so much.
Smita, please.
Thank you so much, sir, for this educative talk. In your experience and in your practice, what is the extent of CNS evaluation you do for patients with CNS IPI, CSF cytology, a CT or a brain MRI, which can help us in planning a preemptive treatment for occult disease rather than a prophylaxis, as we are discussing the number of needed to treat are higher?
Yeah, that's a very good question. So I prefer to do this for all high-risk patients like CNS IPI 4 to 6 or testicular or very high-risk features, also double hit unless if it's a localized double hit. And we do MRI and we do a lumbar puncture with cytology and also with flow. But I also know it can be a logistic nightmare for us to do because MRI scans are not that easy to get, and we want to get it fast, and we get like the reports late, but we try to do it as stringently as possible. And then of course there's the question what should you do if you have a normal MRI and normal cytology, but find some CNS or some DLBCL in the flow only, like minimal involvement. And this is also largely unknown. I would treat them as having a CNS involvement if they are young. But in the elderly, we also know that a lot of these patients with only flow involvement, they actually, even if they get R-CHOP, they never develop CNS relapse. So if the risk of intensive treatment is too high in elderly, I would say I would tend to go only for standard treatment. But in that case, probably this is one of the type of patients that one could consider IT treatment for, right? If you're old and have like flow involvement, but don't dare to give really CNS penetrating agents, maybe this is a case where for IT treatment.
Thank you so much. And any role of radiotherapy to the, CNS radiotherapy in the treatment or prophylaxis? Mostly in the treatment.
Yeah, we never use it for prophylaxis. And again, I think also this is because, and this is what I said first, this is calling it prophylaxis is actually a little confusing sometimes, because when we give treatment up front to treat CNS or to give chemotherapy into the CNS, it cannot be a real prophylaxis. It's more like a treatment of microscopic disease. So in that setting, then I guess radiotherapy could also be effective. Like you could also treat microscopic involvement already in the diagnosis. But I think radiotherapy to the whole brain then probably would lead, it would be too much toxicity and too much neurocognitive decline for too many patients to justify. We also looked at it for treatment of CNS relapse. So this is a different situation to treatment when it occurs. And for elderly patients, it's typically not associated with very good survival, giving radiotherapy alone, but it's a good symptom control for a while, I think.
Thank you so much.
Thank you, Dr. Tarec. My questions are related to Dr. Smita's. So across these various studies which predicted the risk of CNS relapse after various therapies and gave various risk factors, so were the screening modalities same throughout? Was it only IT, MRI, or clinical disease at relapse?
So you mean like how was these CNS relapses documented in the studies?
Yes, or in various studies? Yes.
Yeah. So so typically in the series, I don't have it at heart, remember by heart all of them, but in the series we required either like a cytology or a biopsy or imaging that was consistent with CNS relapse, because as you also know, it is quite few patients. I would say if you have a progression very early on and you see it, the MRI, it looks they can look quite distinct when it's CNS lymphoma. And if you have an MRI saying lymphoma and it's very early after treatment, typically we wouldn't necessarily go for a biopsy. Because
how are you screening these patients?
How we're screening these patients?
Yes.
So in the routine setting, so you're asking how the screening was done in the studies or in this routine setting?
Yeah,
in the studies.
In the studies, how was the screening? Was an MRI or an interthecal?
In most of them,
or yearly basis, or was it only that who had clinical symptoms they were screened?
Yeah, so in the study I showed from the Nordics, the prospective phase 2, all were screened. In the observational studies, then screening was per practice, so that was very variable. So the study we will hopefully publish soon on the large study I referred to, which was shown here as an ASH abstract we presented at ASH last year. I think around 30% of patients were screened with MRI or a lumbar puncture. So it's definitely not all patients in these studies that are screened. So I also suspect that quite a high number of patients in these studies that eventually developed CNS relapse actually had it already at the beginning, just undiagnosed or undetected.
And just correct me for this corollary if I'm wrong. If we screen all the patients with the MRI or IT, let's say on a 6-monthly basis, the incidence of CNS relapse in DLBCL will be far higher than 10%.
Than 5% or because typically the incidence of, so the overall risk of CNS relapse is 5%, but in high risk, maybe it's 10%. And so you're saying if we do follow up with imaging every 6 months, then we will find more cases?
Yeah.
Probably true. Although I would say that we have no evidence that shows that finding these cases before symptoms occurs is very important, and you would need to do a lot of MRIs in a lot of patients to do this practice. And at least in Denmark, we don't have the capacity to do things like this really if there's no evidence for it.
My second question is a very basic one. Why certain sites are more prone for CNS relapse? Is it related to the surface antigen, blood flow, or any other marker? You talked about tropism. So what does that exactly mean?
Well, I mean that some lymphomas, like the ones that reside in the testicle, this testicular lymphoma is homing to an area that's typically absent for lymphocytes. And it's quite interesting that they also typically go to the CNS, and they have also very similar mutational profiles. So this is what I mean by homing. It seems like some lymphomas may be homing more to the what do you call it? Like the immune naive areas of the body, like where you don't typically have lymphocytes.
But the same can't be said about the kidney, the adrenals, gonads, ovaries.
Yeah.
Same can't be said about.
No, I can't say the same about these areas. But what I actually did look into once, because I found it quite interesting that you have the adrenal and kidney, and you have the testicle, and then we found data also showing that the uterus apparently was very high risk. And then I looked into the development of these organs from the whole early fetal development, and as I recall, they come from the same tissue, these organs. So I don't know if it could be something with this. I think you even did write something about it in our paper, but it's so many years ago, and I'm not very good at embryology anymore. But there is some common ancestry tissue for testicles and kidneys, ectodermal, something like. Don't remember what I said here. You have to look it up yourself. I don't remember the embryology, but maybe this is also something that can explain why lymphomas in different areas of the body have a tendency to go to something that maybe be developed from the same type of tissue.
And my third question is, with respect to the high-risk sites, we agree that R-CHOP doesn't have a great CNS penetration. In such a scenario, regimes like IR2 with lenalidomide, ibrutinib, and rituximab with slightly better CNS penetration, will they have perhaps a lower risk of CNS relapse?
Yeah, so I think the lenalidomide addition to R-CHOP has not been really documented to lower risk of relapse in the clinical studies.
Talking about the triple drug regime, IR2, ibrutinib, len, and all these three.
Oh, so Yeah, so if you add both ibrutinib and lenalidomide and R-CHOP, so all of them together, or perhaps there would be a... Sorry?
Just rituximab, ibrutinib, and lenalidomide. This new regime that came up somewhere around a couple of years back.
Yeah, this is something we never used for DLBCL. Never used. Probably that's more like a treatment that could be relevant for primary CNS lymphoma or something like this. This is something we never did for upfront treatment for DLBCL.
We used it for a couple of patients at relapse or early relapses or not responding to the current thing. At least one of them.
Yeah.
So one of them had a pretty good response systemic and was able to progress to transplant as well. So,
that's great. Yeah. But I'm sure it's effective and active. The problem in Denmark now, lenalidomide is off patent, but ibrutinib is not. So lenalidomide just got off patent, I think this year. But this could be a very, very expensive treatment for us to use. So it would be like it's very expensive. So I think you have some different ways of accessing medicines.
So that's the positive aspects of practicing in India. We have a lot of generic medicines which are available at an earlier time.
Yeah. And you're very lucky to have that because we don't have it, so we have to pay the full price for ibrutinib and lenalidomide, and this is beyond what our budget can carry for all patients. But now Len is out of patent.
Thank you, Tarek.
Yeah, Tarek, I have one quick question. In your clinical practice, how you decide the intercalated therapy versus the end of treatment high-dose methotrexate?
Yeah. So some months ago, or maybe half a year ago, before last ASH, we typically always try to give it intercalated because of the Nordic study, and this study was out of the Nordics, and kind of felt this was a good approach. Since the study in blood by Wilson came out, showing that they had the same CNS relapse risk, but they, on the other hand, had a quite substantial risk for delaying R-CHOP and with the risk of losing systemic disease control, then I would never consider it anymore personally as intercalated because I think it's too complicated. So I would prefer to do it after treatment, but I don't think there's a right or wrong here. I just think I've seen quite some patients getting delayed in R-CHOP, and also it's quite tough for the patients to have the methotrexate and then the R-CHOP. Of course, you can complete the full treatment faster, and maybe some patients prefer that, but I think still you have an increased risk of complications, and also just occasionally you end up having serious kidney injury from methotrexate. And for example, if you have given all your R-CHOP and you have a good systemic disease control, maybe it's not so problematic to halve the kidney function as it would be to do it already after first cycle of R-CHOP and then go through the rest of the treatment with a very, for example, poor kidney function or something like this. So I think there could be some problems too.
So for elderly population, say more than 65 years of age, so end of the treatment, you use 3.5 gram per meter square, you just cut short the dose to 1 gram, around 1.5 gram like that. Or you just
sometimes you go down to, I would say 65 would probably still be 3 gram, but maybe more than 70 would maybe go down to 1 gram per square meter. And then also one caveat for high-dose methotrexate, but this is probably more if you give it intercalated, is if patients have like pleural fluid or ascites or things like this can be really tricky and you cannot really eliminate it. So, but I'm always a little more concerned with elderly patients and high-dose methotrexate because I think they really run a risk of toxicity, and in light that you may need to treat, like let's say just 60 patients to avoid one relapse. If it works, then like imagine giving 60 elderly high-dose methotrexate, I wonder if also sometimes you get one serious complication in these patients. So what do you do can I ask what do you do in India?
Yeah, so I use the end of treatment most of the time. I use 3.5 gram per meter square up to 65 years of age. If the patient is more than 65, we generally cut short the dose to 1 to 1.5 gram per meter square, 3 doses, 15 days interval.
Yeah. And how many cycles do you give?
3 cycles, yeah.
3 cycles?
Yeah.
No, two. Okay, we typically give 2, but again, nobody knows what's right? So
they say 2 to 3 like that, yeah.
Yeah.
So there is a question from the audience, Dr. Rani. Dr. Rani is in panel, I guess. So can you please share your experience of intrathecal rituximab?
Actually, I have absolutely no experience with that. I never, unfortunately, did this, or I cannot even say I even studied the literature on this very well. So unfortunately, I'm not really able to give a good answer on that. But sorry for that.
So just quick comment that ibrutinib in CNS lymphoma, how you want to place this drug in future? What is your take on?
I think that is a very promising, like I think generally the BTK inhibitors and some of the newer ones like zanubrutinib look like very promising agents for CNS lymphoma in elderly or at the time of relapse. I still think, I don't believe it would be as effective as, for example, Matrix or with consolidations, transplantation, as we do now for younger in Denmark. But I think for the elderly population, could be very interesting also for possible combinations with high-dose methotrexate, although there are so many, I don't know the interactions with high-dose methotrexate, but like some sequential treatment or some maintenance treatment, things like this. There's a lot of interesting things about BTK inhibitors in CNS lymphoma. But I'm not sure as a single agent, as the only thing, it would be very successful in giving durable remissions, but I don't know. That's just my expectation.
Professor Tarek, it's a lovely discussion, and thanks a lot you're sparing your Saturday. I thank all my panelists for sparing their Saturdays evening, and I thank all the attendees who had just listened to Dr. Tarek, and I'm sure the practice of in India with this particular aspect will change after Dr. Tarek's lecture. Thank you, Dr. Tarek, once again. Good night from us. Thank you very much. I have to say, I really enjoy having these interactions with you. So thank you a lot for inviting and enjoy your evening. And thanks for spending an evening with me on this. It's a great pleasure. Thank you, Kalpesh and the MCure for this wonderful meeting. Bye-bye. Bye.